Patrick suffers from various factors contributing to his respiratory systems. These include his signs of dyspnea and his persistent cough resulting from his current COPD condition. His current age and smoking history can play large factors to what permanent changes have occurred to his respiratory system. As Patrick is 78, his age does affect his overall lung capacity and function. Although his age does contribute, Patrick's 40-year history of smoking plays the direct impact of his respiratory symptoms. Tobacco smoke, once inhaled, slows the movement of cilia along the trachea and reduces their length. This loss of effectiveness leads to inflammation as well as increased mucus production of surface goblet cells, resulting in excessive secretion of mucus in lungs. The inability to expel mucus through coughing while excessive mucus is still being produced causes cough persistence. Furthermore, smoke causes inflammatory cells to arrive in the bronchioles, causing further inflammation and thickening of the airways and small vessels in the bronchioles. Over decades, the lungs adapted by remodeling and changing to adapt to cigarette smoke, causing squamous metaplasia. This makes surface lung cells transition and be replaced with stratified squamous epithelium, causing further airflow limitation and irritation to Patrick's lungs. Another factor is his dyspnea, resulting from years of smoking and associated to Patrick's COPD and post-MI. Dyspnea involves the stimulation of upper and lower receptors of the airway, chest wall, and respiratory center by the central and peripheral chemoreceptors relayed overall to the CNS. Patrick's prolonged exposure to smoking has led to the depletion of sensory nerve neurotransmitters in the CNS, causing serious affective breathlessness. Patrick's past left MI can also be a factor behind his dyspnea. The low cardiac output from the heart is unable to meet the oxygen demands of the body, causing ischemia from inadequate tissue perfusion. Cardiac insufficiency thus links to pulmonary edema in the lungs, further presenting shortness of breath presented by this dyspnea. Patrick weighs 95 kilograms and has a waist circumference of 104 centimeters, indicating he is overweight. This factors to his increased heart rate, as excessive body fat can restrict the blood flow through veins and arteries. Living a sedentary lifestyle can also weaken the myocardium, which can decrease stroke volume, resulting in increased heart rate to reach the demand of oxygen in the body. The main factor contributing to Patrick's high heart rate is evidently the myocardial infarction to the left ventricle. Myocardial infarction is caused by atherosclerosis, where a buildup of plaque in the arteries causes a blockage. Due to this damage, the heart must pump faster to supply the body with sufficient amount of oxygen, as the blocked artery complicates this.
Smoking is also a major contributing factor to Patrick's high heart rate, as the nicotine contained in cigarettes stimulates the body to produce epinephrine, which increases heart rate, blood pressure, and demands the heart to work harder. Due to his excessive history of smoking, Patrick was also diagnosed with COPD. COPD is essentially a disease where airflow is obstructed in the lungs due to inhalation of harmful substances and gases, such as in Patrick's case, cigarette smoke. As the lungs are damaged, the heart will receive less oxygenated blood, which results in an increase of heart rate, as the heart now requires to pump faster in an attempt to reach the demand of cardiac output and oxygenation needed in the body. This reduced level of oxygen in the blood also results in lower levels of hemoglobin, which is a protein found in red blood cells that are responsible for the transportation of oxygen around the body. This means Patrick's heart must pump faster in order to compensate for the poor oxygenation from the lungs, which is caused by COPD.
Chronic obstructive pulmonary disease is an incurable inflammatory respiratory condition that limits airflow and is often caused by exposure to tobacco smoke. As Patrick was a cigarette smoker for approximately 40 years, this would be the primary instigator for his diagnosis of COPD. The disease causes inflammation to the airway, respiratory bronchioles and alveoli, and pulmonary blood vessels, as well as chronic irritation of the airway, mucus production, and pulmonary scarring. It limits airflow due to damaged elastic recoil, in addition to airflow obstruction from increased mucus secretion and mucosal edema. As smoke is inhaled, inflammatory mediators damage the lungs by destructing tissue and disrupting the body's defense mechanisms and repair processes in the lungs. This essentially leads to structural changes in the lungs, as protease activity, breakdown of connective tissue, is increased, and antiproteases, the protectors of tissue breakdown, are inhibited. Manifestations of COPD include the intermittent cough, dyspnea, and fatigue, which are all symptoms that Patrick displays. COPD and cardiovascular diseases also come hand in hand, as smoking is a primary risk factor for both diseases. Patrick's left-sided heart failure has been majorly prompted by his past MI. As mentioned briefly before, myocardial infarction is caused by atherosclerosis. As blood continuously hits the plaque buildup, high blood pressure can cause the buildup to rupture, and as a result, a clot is produced which further obstructs the artery until it is completely blocked, limiting the airflow of oxygen-rich blood to the cardiomyocytes. An MI is the result of prolonged ischemia of the heart muscle when there is insufficient blood flow to an area of the myocardium, causing necrosis. Granulation tissue is produced at the formation of necrosis tissue and eventually attracts a vast deposition of collagen, and collagenous scar is produced. This has the predominant effect of his worsening left-sided heart failure. As Patrick's left ventricle has sustained permanent damage due to necrosis, this has left his left ventricle in a weakened state. The left ventricle vastly supplies the heart's pumping power and is essential for normal and balanced function. As Patrick's heart is already weakened, the left side of the heart has to work drastically harder to meet the body's demand for oxygen-rich blood. Because the myocardial infarction left Patrick with collagenous scars on his left ventricle, it loses the ability to contract normally with an increased work demand. The left side of the heart then begins to fail as oxygen demand is not met. As the cardiovascular and respiratory system independently confide in one another to maintain homeostasis, Patrick's respiratory system, affected by his COPD, can present as a viable factor to his worsening left-sided heart failure and can potentially exacerbate one another. When blood is not properly oxygenated due to COPD, extra stress is placed on the heart to compensate for the reduced oxygen levels received. Conversely, pulmonary edema caused by heart failure and backflow can increase the difficulty to breathe. The overall lack in transport of oxygen causes the heart to weaken as it overworks to counteract for these losses and also results in edema in the legs, which is mentioned further on.
Patrick was diagnosed as COPD due to his long history of cigarette smoking, which was the underlying cause of the myocardial infarction. Although smoking could have caused COPD and his myocardial infarction during a similar time frame, Patrick's COPD was a main contributor, along with his MI, in the development of his worsening left-sided heart failure.
Right-sided heart failure is an enlargement of the right ventricle due to increased pulmonary hypertension and predominantly occurs as a consequence of left-sided heart failure. The right ventricle transports returning blood from the body to the right atrium of the heart via the pulmonary veins and then to the lungs in order for oxygenation. When left-sided heart failure occurs, gradual pulmonary hypertension causes the right ventricle to compensate for the left ventricle and eject higher afterloads to meet the physiological demands. The chamber wall of the right ventricle is exceedingly thinner and physically remodels to indemnify the increased afterloads. Ventricular hypertrophy will result to allow the thickening of the chamber wall, thus improving its capacity to compensate for the left ventricle. This continuous hypertrophy causes dilation of the chamber wall until the ventricle itself begins to reduce in capacity. This gradual reduction and continuous blood backflow increases stress on the right ventricle and with time will begin to fail. As Patrick also suffers from COPD, it can additionally have a direct influence on the heart's right ventricle. Abnormally low levels produced from Patrick's COPD can increasingly result in further pulmonary hypertension when blood pressure inside the arteries rises. This excess strain from this hypertension on the right ventricle can exceedingly increase the risk Patrick already has for right-sided heart failure. As a result of this backflow and strain on the right ventricle, fluid is forced back through the lungs, the right ventricle, and atrium and back into the veins where fluid accumulates, causing edema. Patrick's swollen legs from the knee down clinically indicate peripheral edema caused by the accumulation of the backflowed fluid in tissues perfused by the peripheral vascular system as a result of potential right-sided heart failure.
Due to the myocardial infarction located in the left ventricle, the myocardium is replaced with collagenous scar tissue from the tissue necrosis caused by inadequate oxygenation of myocytes, which essentially decreases contractility of the heart and forms a hypertrophy. With this formation, the left ventricle reduces in size, which decreases cardiac output and lowers systemic blood pressure. The juxtaglomerular apparatus in the kidneys detects the decrease of blood pressure and secretes renin, which converts angiotensinogen found in the liver to angiotensin 1. This is further converted by angiotensin-converting enzyme to angiotensin 2. Angiotensin 2 is a potent vasoconstrictor that narrows blood vessels, which increases blood pressure in an attempt to maintain homeostasis. With the release of angiotensin 2, aldosterone is triggered to release from the adrenal cortex, which increases the reabsorption of sodium from the renal tubules and into the blood, thus resulting in his elevated sodium levels evidenced by his blood test. With the release of aldosterone, potassium is generally excreted, so Patrick's abnormally high levels of potassium is recognized as hyperkalemia.
Patrick may have issues with his kidneys as it is evident that this excretion is not occurring, which can lead to arrhythmias as high levels of potassium interfere with the heart action potentials. Abnormal heart rhythms and fatigue is caused by low calcium levels known as hypocalcemia, as muscle fibers use calcium as the main regulatory and messenger molecule. Reduced calcium release is therefore a main component in skeletal muscle fatigue. Patrick also has low levels of hemoglobin due to his decreased levels of oxygen traveling around his body from his COPD, MI, and left-sided heart failure. As hemoglobin is a protein in red blood cells that carries oxygen, if there is limited oxygen to carry, then hemoglobin levels in the blood will also evidently be low. This can also cause fatigue, which Patrick displays as the muscles are not supplied with sufficient amounts of oxygen. One additional blood test that could be used is the brain natriuretic peptide BNP test. BNP is produced within the chambers of the heart and secreted by cardiomyocytes in the heart's ventricles when abnormalities arise in heart pressure. When BNP is secreted by the heart, the hormone vasodilates vessels within the body to take pressure off the heart. Levels of BNP rise when heart failure develops or worsens and decreases when heart failure is stable. Generally, BNP levels below 100 picograms per milliliter (pgml) are considered normal but can vary on age and sex. BNP levels for men aged approximately 60 to 80 should have a BNP range of 53 to 91 pg per ml. In Patrick's case, his BNP test results would be over 100 pgml mark, as he is already suffering from worsening left-sided heart failure, and his presented peripheral edema indicates a further risk of right-sided heart failure.